All right, well, thank you, everybody. I'm so glad you can be here. This is the Peggy Lillis Foundation's second C. diff Summit and National Strategy meeting. We are delighted to have five really incredible panels this afternoon. I'm going to introduce the first one, which is about the new federal landscape. Post-election, what's going on, what are the opportunities, what are the risks? I also want to, again, reiterate our gratitude to our sponsors, which are Sanofi Pasteur, Cristivo, Cepheid, and the Pew Charitable Trusts. We could not have done this without you. And we also want to thank all of the panelists for their time. After each session, there'll be hopefully significant time for Q&A. So we'll turn it over to Amanda Jezik, who's going to be moderating this first panel.
Hi, good afternoon, everyone. I know this is post-lunch, so we're going to try to be very high energy for everybody. As Christian said, this panel is going to be talking about the federal landscape, what kinds of federal efforts currently are underway to help address infection control and prevention, antibiotic stewardship, and research and innovation for new preventive measures, diagnostics, and cures. We're going to talk about the opportunities that there are to continue making progress on a lot of these areas, as well as what some of the larger federal proposals around federal budget and pieces of legislation that might pose threats to some of the progress that we've been making recently. So my name is Amanda Jezik. I work for the Infectious Diseases Society of America, and I will take a few minutes for each of our panelists to briefly introduce themselves and give a few opening comments.
Hello, my name is Janelle Krishnamurthy. I'm with Merck, and I just wanted to first start the session by saying thank you. Thank you for all that you do and for being here today and being interested. I'd like to say you all have made a difference in what has happened in changing the landscape. As you may recall, I mean, we now at NIH and BARDA, they have had initiatives in those areas, CDC working on stewardship and surveillance, USDA doing antibiotic research, and also the VA and DoD. And I have to say, you've done that through champion development, and you've also through legislation, getting GAIN passed, which is incentives in the regulatory side. Just recently through the Cures Act, getting the PATH Act and being able to have this new pathway. So I just want to say that, you know, things may be shifting, and so that means we have to roll up our sleeves and get more reinvigorated and keep on working, so we're all gainfully employed. But it's imperative that we do that because why? We have no other choice. We have to do that. So, you know, Merck is one of the companies, Sanofi and other of big companies that are still in this field. We've been working on antibiotics for 80 years now and are continuing to be determined to do that. But, you know, there are still a lot of challenges, and there's a reason that there's only a few big manufacturers that are in this place. And so I'm looking forward to continuing this discussion today and talking about how we can continue to partner together and really make a difference so we can get more people involved and more manufacturers that are coming up with more, antibiotics and others, vaccines for prevention, so that people can be cured and prevent C. diff. So thank you for having me.
Thanks. Hi, I'm Becky Sally. I'm with Trust for America's Health. We are a small, nonprofit, nonpartisan public health policy organization. We sort of think of ourselves as a mini think tank where we do policy research, but then also have a pretty strong federal advocacy arm. We are a unique group because we don't take any government or business money. We're purely foundation funded. And that means we also don't have members. So we depend on partnerships with others, much like you guys do, to work and reach out to Capitol Hill and try to get great policies for prevention enacted. Infectious disease prevention is obviously one of our big buckets that we work on. I was connected with Christian because of our work on the Prevention and Public Health Fund, which I know has come up a few times already today. Trust for America's Health was one of the leading groups that helped get the Prevention Fund passed as a part of the Affordable Care Act. My colleague Janelle was working on Capitol Hill and actually wrote the whole thing, I believe. So we have a very... The Prevention Fund, not the whole ACA. And so the Prevention Fund has really been successful in infusing a whole bunch of money, extra money into the CDC and the public health system. because of the Budget Control Act, there have been a lot of budget cuts all around. The Prevention Fund has really succeeded in sort of buffering the CDC against some of those budget cuts. Now we're obviously very concerned because the AHCA that they are pushing on the Hill, which actually this week seems to have come back to life, repeals the Prevention Fund. And I can go into the whole thing, but I know we're keeping this brief. But we're very concerned about that because right now it's 12% of the CDC's budget. And so that would impact not just their work on healthcare-associated infections, but sort of public health across the board. So we do a lot of work organizing with our DC public health partners and other groups. But then as a group with no membership, we try to work with those folks on activating people outside of DC, because it really is so important that folks on Capitol Hill are hearing from people around the country. I have definitely noticed in the past couple months, every time I go to Capitol Hill, the phones are ringing off the hooks in the offices in the way that they never were before. And people really do listen to that. Good work, everyone. If you talk to people on both sides of the aisle, no one is pro-healthcare-associated infections or anti-public health, but they need to know what this money is being spent on and that people out there really do care about it. So getting people energized and making voices heard is really important. So I'll stop.
Great. Thanks, Becky. I'm Bill Franco. We represent the Antimicrobial Working Group. Essentially, it's 13 companies, all pre-revenue companies in the antibiotic development space. I thought Amanda's presentation this morning on advocacy was really excellent. And, you know, we're all lobbyists. We engage on Capitol Hill. That's what we do. But you have the strongest voice by far. I think the patient stories, I think what Amanda laid out was just so right on and so spot on that there's so many ways you can connect on Capitol Hill. But I think telling your story, I think there's sometimes, you know, we see that people get sort of intimidated by the thought process of being before a member of Congress or a staffer. They're just people, and they want to know your story. That is just absolutely so critical. I was a former staffer, you know, and I thought, you know, if we got constituents that sent a lot of postcards, they were just kind of repetitive postcards, my member would kind of pay attention to that. But if it was handwritten letters, you know, to the congressman, or, you know, meetings at town hall where people were telling their personal story, and it, you know, it was more than just kind of the postcard kind of variety type advocacy, those members would pay attention. So keep doing what you're doing. I mean, we know the staggering statistics. Antibiotic resistance, over 2 million Americans are affected by resistant infection each year, 23,000 of whom die as a result. And the sad reality is that less than 5% of the pharmaceutical investment goes toward development. But, you know, there are, you know, if you think about only 5 of the top 50 pharmaceutical companies are investing, Merck is one of those leaders, most are being developed, 80% are by small companies. And if you think about, you know, these are pre-revenue companies. If you go through the process and you take, you know, up to 10 years developing a product, $600 million to $1 billion of investment, you know, on average, you could see where it might take you 23, 25, 28 years to recoup your investment. And, you know, so I think that's important. It's a sad reality that, you know, unlike other drugs, I think they're somewhat generally undervalued, you know, by our current system. It doesn't need to be that way. I think the stewardship things that are being done, you know, applaud IDSA and all of you in the room. You know, it's critical to addressing antibiotic resistance. It's absolutely important. We should use the right drug, you know, the right person at the right time. I mean, that just makes so much sense. This will slow resistance, we know that, but these pathogens will continue to evolve. I mean, that's just a reality of what we're dealing in this globally. So, you know, for us, for our coalition, we really believe you really have to pair stewardship efforts with policies that incentivize innovation. So I'll just stop there because I know Amanda's got a list of topics that she wants to review and tease out a conversation with all of you.
Great. Well, thank you. I think all the opening comments were really helpful. I thought it would be a good idea to spend a couple of minutes talking in a little more depth about prevention. And to me, when I think about preventing C. diff, it's not just the sort of traditional infection prevention efforts, though those are certainly central and critical, but it is also antibiotic stewardship and ensuring that we are not overusing and misusing antibiotics, since we know that antibiotic use is a key risk factor for C. diff. And I think that looking back over the last maybe 2 years or so, there have been some headway in the federal efforts to prevent infections, to prevent antibiotic resistance, to promote stewardship. And I'm wondering if you all could speak a little bit to some of the progress that's been made in these areas, what opportunities you think there are for advancing that progress with this Congress and with the new administration, as well as potential threats on the horizon that could halt that progress.
So I'd say, I'm trained as a pediatric clinical psychologist by training. So, the first stage is raising awareness, right? And I feel like over the last 8 years or so, wow, did we come a long way of raising awareness. I mean, HHS, we had the National Action Plan. We're now getting goals and surveillance. And we also had CMS that was talking about for a condition of participation that folks were have to be collecting data and, for participating in Medicare. And I mean, I just feel like those were kinds of discussions that just weren't happening before. So we really, we just, that just moved the needle. Now, at the same time, I think you all know with, the National Action Plan, they had for C. diff that, we were supposed to reduce by 30% or so the hospital cases of C. diff, and instead it increased by 18%. So, I mean, oops, that didn't, now at least the positive, we have the data on that, right? We know that something's happening here. Now, I think in 2020, we want to, again, reduce by 30%. So, again, this goes to more work needing to be done. I think also what's been critical over these last 8 to 10 years is we have the data on making the economic case. Now, for each case of C. diff, it's like $1 to $1.6 billion a year to be treating. So what I'd say right now with our new administration and many new members of Congress, we really have to educate. I mean, what's great is we have the data, we have the information. And a lot of the people are the same people that are there, maybe the new people in the top ring, but you have a lot of the same people, and then also the new people, something I always think is an untapped person many times is the Surgeon General. And the Surgeon General is not someone that's passing laws and things like that, but really being the public spokesperson for the nation, right? And wow, wouldn't it be amazing if we could get the Surgeon General to do a report on this? I mean, I just think that is something, and we're gonna have a new one, so let's educate, this is an opportunity. So, I think, I'll stop there, but also, quality measures. There's a lot we can do more in the stewardship that then ties it back to actual reimbursement in ways that it's not fluff anymore, it's very real.
That's great. Yeah. I mean, I guess
The threats.
of the threat. Great, I get to do the threats.
Sorry.
I'm just thinking of the budget as one huge threat for everything that we all care about. Besides the prevention fund, the president put out for next year what they're calling a skinny budget, which means it's a very, very broad, vague outline for what he wants to do for funding next year. And his outline included an 18% cut for HHS overall. So we don't know what that means, how it will be divvied out. What we've heard from people at the CDC that we've talked to sort of behind the scenes is that they are working up numbers for a 20% cut, which is really scary to think about. But most of the Republicans that we've talked to on the Hill have pretty much dismissed that budget. We've been really pleasantly surprised that most of the Republican offices we've gone into have said that budget is DOA. We can't overemphasize how much that's not going to happen. But at the same time, they're going to have to give the president some kind of cuts. Like, they can't just ignore it completely. So as Janelle said, education, just going in there and making the case and sharing your stories and talking about why this investment is so important. It's just even more critical now than it was before.
Yeah, the only thing I would add is just that antibiotic resistance doesn't discriminate against, the left, the right, the middle. And if you talk to any staff on Capitol Hill, Democrats, Republicans, independents, they really care about this issue. And members across the board, I think, really care about research. As evidence, if you look back at last year, the 21st Century Cures legislation that President Obama signed into law in December before he left office, that was the accumulation of a couple of years of hard work, both sides of the aisle, to craft a bill that was bipartisan in nature. It was non-controversial, bipartisan, made a lot of sense. And so I think, on the Hill, we get sensitized by the optics of the news media, kind of the loudest voices in the room. And I think when you actually see the work that's being done, it's so critical, that you continue to tell your story, that you continue to educate. They want to know. A lot of staff people, super smart people, they might look like they're 15 years old, but they're super smart young people. They might be an inch, deep, a mile wide on issues, and they need to be educated. They need to have those stories. They just don't, they don't want big, necessarily sign-on letters. What they're looking for information that they can best make their case with their boss.
I'll just make a follow-up comment to something that Janelle said. She referenced this national action plan that we have for antibiotic resistance. And for folks who may not be as familiar with it, this was something that was launched in 2015 that I think all of our organizations had a lot of input in, and we're incredibly excited to see move forward. And it's something that sets out goals for 5 years and benchmarks for reducing various infections, for spurring innovation, for antibiotics and diagnostics and vaccines. And it's something that Congress actually approved new funding for 2016, so that some progress was able to be made. And I think there are concerns kind of on two levels. One is the funding, which we definitely covered, is definitely a big concern. And the other is that, this is something that was launched by President Obama. This was something that he personally took a very strong interest in. And I think that we've been very conscientious about presenting this to the new administration as a public health crisis, something that is important to all of us, certainly not something that is kind of an Obama legacy or anything like that, because we want to make sure this is embraced by all leaders. So I think that's just kind of something important for us to think about in our messaging, and to recognize that we need to make sure that there not only is there money, but that there's strong federal leadership and interest in driving this forward. The conversations that were happening around requiring stewardship for all hospitals that are involved in Medicare, which is pretty much all hospitals. That was a really robust conversation and great proposal from the Obama administration that didn't get finalized. So the Joint Commission does require stewardship programs, and that's wonderful, but having a strong federal requirement to really ensure that there is more accountability is definitely something, at least at IDSA, that we view as something that still needs to get done. So I want to shift a little bit and talk about research and innovation, because while of course we want to prevent every infection that we possibly can. Well, first of all, there's research and innovation that needs to happen for vaccines to help with prevention, but we also know we're not going to prevent everything. We need new cures, and we need new diagnostics so that we are catching these things early. I think that's something that our sepsis speaker really hit home for me when he was talking about cases that are missed. So I was wondering if you could talk a bit about kind of what the landscape is, and you touched on this a little in your opening comments, kind of the challenges for innovation, some of the recent success and how 21st Century Cures is going to help, and then sort of what's on the horizon. What are we pushing toward now to make sure that we get the innovation that we need?
I placed on the table op-ed piece that was written by former Secretary Mike Leavitt, Secretary of HHS, who's governor of Utah. And if you have a chance and can pick that up, it's a short op-ed, but he talks about pandemics, Zika, Ebola, and he makes the point. He said, when pandemics occur, our first response is to question why we couldn't anticipate the onset of the disease and why antidotes weren't immediately available. And he kind of makes the comparison to sort of like this lack of preparedness, almost, like not having adequate water resources to address a fire. It's like what is clear is the lack of preparedness is not due to the novel nature of the threat. Outbreaks are as predictable as fires. And the point he's making here, there's another threat that largely goes unnoticed, given that it's not just predictable, but it's the ever-present drug-resistant, bacteria that we're faced with. And I think, right now in Washington, there's a whole lot of conversation going on about various push and pull incentives. The GAIN Act that was passed in 2012, that was a pivotal, very important element in incentives. A lot of these companies, our 13 companies, would not exist without that. But I think there's general recognition in Washington that that was a great start, but that we need to clearly do more. We've got challenges in terms of, I'll give just one example, would be Medicare reimbursement. You're familiar with the DRG system. Everything in government has a code, including those costs in a hospital setting. And within that DRG system, there is, and again, I come from the perspective, we all do, that a generic drug could be perfectly appropriate for a patient. If it's the right drug for the patient, that should prevail, and the prescriber prevails, I guess. But when an infectious disease doc, and there are plenty of docs in the room, if they know, in their heart of hearts, that that drug is not going to have a good outcome for that patient, and then there's pressure on them to, just prescribe a drug that's pennies on the dollar, and it's a cost focus, we need to, change that paradigm. It should be the appropriate drug for the patient. If you can have a patient that can be released on day 1 after drug therapy and come back on day 8, and you can avoid all those hospital costs, I think unfortunately we sort of have a system, we don't score for prevention. We silo those costs. And so there's a pretty important big discussion going on both on the Senate side and the House side, the Senate Finance Committee and the Ways and Means Committee, of how can we organize our reimbursement system so that doctors do have those types of drugs in their toolbox. And again, you want to use those sparingly. You don't want to use those every time. You don't want to increase antibiotic resistance. You want to do the right thing by the patient. But I think that's important. So the main point is that GAIN was the right incentive at the right time, and I think a lot of members, both sides of the aisle, are trying to figure out what do we do next, and I yield to my colleagues here on some of these other incentives.
So I'd say, Bill is right. Like, we are up to here. We're so interested. We are fighters and champions, everyone up here, on antibiotic resistance and developing antibiotics. But I do want to say, and you can throw something at me, Bill, if you disagree, is that you still have to make people champion this issue because there are so many. I mean, you all are watching the news. You see all the things that are going on up there. This, unfortunately, isn't the first thing everyone's thinking about. It gets lost. And I mean, and a lot of what's happening up there is just, we're just trying to keep the government funded, right? So it doesn't shut down. I mean, just to put, it's not why. And so where I am going with this a little bit is that it's also not just coming to DC, and I think Bill was alluding to this earlier. This is going to be a grassroots and a grass tops, multi-sector, challenge that we're on and path that we're doing. And so many times, I mean, the whole month of August, they're all home in their districts and in their states. I would, I don't know where Christian is, but I would make it a challenge that everyone sees their congressperson or senator, at home during that month. I mean, and contact them. So, and I think the other piece on just getting back to, sorry, Amanda, what you actually asked about.
That's okay.
on research and development is, for Merck, we have to make decisions, right? We right now spend around $7 billion a year on research and development. So, but we do things in vaccines, Hep C, oncology. We're right now, President Carter was lucky enough to use Keytruda, and now his cancer is not seen. We're doing 300 trials and 30 different tumor types there. Well, when we're looking at the budget of $7 billion, how are you going to invest that in your different therapeutics? And this is where Merck has been very dedicated to this, and what makes this issue challenging but so important is that it is an issue where you come up with the drug, you spend those 10 years, and then after that, you say, don't use it. You know what? If you don't have to use it for 5 years, don't use it. Keep it on your shelves. Only use it when you need it, because once you start using it, then resistance will start. But that market doesn't quite work right? If you're trying to show you're getting a return on your investment, you don't want a return on your investment at the beginning. However, in those first 5 years, you need to already be reinvesting, starting that next 10 years of developing the next drug that will have to be out there. So that's the challenge, and why, as Bill and Amanda were talking about the push-pull incentives of you need regulatory easements, where I think you all and everyone's been more successful in with FDA coming up with the limited pathway, coming up with GAIN and some other things. And now it's looking at also how do we change the reimbursement system and how that works.
The one thing I would add, because IDSA has also been very engaged in trying to promote incentives for antibiotics, because while we're incredibly grateful for Merck and for the small companies that are involved in antibiotic R&D, that's pretty much it. There's a couple of other players, but the vast majority of pharmaceutical companies, particularly the big ones, they're not doing antibiotic R&D at all. It wasn't like that 20, 30 years ago when we were getting a lot of innovation in this space. So we need some pretty big proposals out there. And one item that IDSA is working on that I think each of the organizations that are up here have been supportive of is a bill called the READY Act. And this is something that will provide a new tax credit for new antibiotics that would address an unmet medical need. So again, it's not antibiotics for my 4-year-old's ear infection, because we have stuff to treat that. It's antibiotics for the superbugs that people are dying from because we don't have good treatments, as well as for rapid diagnostic tests, which is something that we didn't talk about as much, but is essential for making sure that we catch people's infections early enough to make a difference, and so that we differentiate whether someone's infection is bacterial or viral, so that we don't give someone antibiotics if they don't need them. So we talked earlier about how important it is to have an ask when you're talking to your members of Congress. So this is something that hopefully you can consider being an ask that you might want to encourage your members of Congress to support.
One
sure,
thing,
please.
So we're talking to you all about incentives, right? And you all understand this issue in antibiotics. But again, another thing you may have read once or twice lately is drug companies, greedy drug companies. They are making all these profits. And just the climate around the pharmaceutical industry and innovation. This comes back to having to educate the difference with this class, because people do not understand. There's many congressmen and senators that talk. They don't understand the difference between antibiotics, how the market works in antibiotics versus some other areas. They also don't understand that, Mr. Shirelli, who was the pharma bro guy, the hedge fund guy, that's different than us, who does pharmaceutical business, $7 billion a year in research and development. So again, when you're talking to folks and educating, it is just that, you just have to underscore that that's the climate when you're talking about developing antibiotics that is kind of in the background.
Before we turn over to the audience, I wanted to ask one more kind of bigger picture question, because we've gotten into a fair amount of weeds, which I think is good. We all live in the weeds. So, but I think some of the challenge that we all have is not just making these arguments and knowing sort of exactly what things we want to ask for, but rising above the noise. You mentioned, you see all the stuff that's going on in the news. There's all the stuff about what the new health insurance system is going to look like, and there's what we're doing in Syria and North Korea. There's tax reform, all of these big picture items that are not only taking up the public attention, but taking up the attention of members of Congress. So how do you recommend that all of us as advocates make people hear and understand the urgency of this issue?
I would say I thought Janelle hit the nail on the head is that virtually everybody has a story. Everybody that you meet members of Congress, you meet staff people, people that come to Washington, they all have a relative, a friend, a coworker that's had, some serious, situation. And I think it's important, to not lose sight of that. And I think Janelle's right. I mean, they're faced with so many issues, but I think this is up close and personal from a healthcare perspective, that these are things, to the extent that you can keep those memories and make sure that you connect the dots when you're having those conversations, because they actually really do care about these issues. And I think it's absolutely critical not to lose sight of that. It's the personal stories that are absolutely important.
Yep, I'll chime in on that. I'm also a former Hill staffer. I can still remember certain, the Alzheimer's Association came in and hearing different stories. Some of them just stay with you forever, and you can't really underestimate the power of those personal connections and personal stories when it comes to getting someone's attention. Chiming in, I think just to reinforce what everyone has said, just the phone calls, people really pay attention to phone calls, and they're not scary because you're probably just going to talk to whatever intern answers the phone, but they'll listen to you, they'll write it down, and they'll report it back. And at the end of the week, they'll say, oh my God, we got like 50 phone calls on healthcare-associated infections. Maybe we need to think about this a little bit. We need to pay attention. What's this bill they're asking us about? People really do pay attention to that stuff. Letters, meetings, or town halls in the district. I know this is not a meeting on healthcare reform, but there are a lot of coalitions working on healthcare reform that are tracking town halls. So you could go online and find out when or where your member of Congress is having a town hall. Technically, they should be also publicizing that themselves, but they're not always doing that these days. Turn up at a town hall, have someone film you, ask the question, and film the answer. Those kind of things really get people's attention. You can request meetings in the district. There are so many ways. I know people think Washington doesn't listen, but they really do pay attention, especially when it's their constituent and a real story like that. And you don't know someone in the office. We do work on opioids. I went on a lobby day on opioids a couple years ago, and of the 8 staffers we met with, 6 of them knew someone who had passed away of an overdose. I would have never guessed that. It was a really sad day. But you don't know until you go in and talk to them. So I just want to also emphasize how important that is.
I would just say to what Becky was just saying, and you just never know. Some folks think you need to talk to the senator or you need to talk to the congressperson. Staff does so much work. And I don't know if the gentleman that was here on sepsis, I remember I was lobbied on sepsis. We then did 2 full committee briefings. We did a hearing, and our chairman knew nothing that meeting had happened, but that had such an effect on the staff that we then pitched it to the senators and we said, you need to do this. This is really important, and things got moving. So don't underestimate what staff can do.
Oh, absolutely. That's a great point. I think we're all recovered Hill staff. So, well, we really do want this to be a conversation. So we would love to open it up and get questions and comments from anyone.
Do you guys have a feel yet for the new Surgeon General? I was trying to find out. I know she's a nurse, which makes me happy. Have you guys gotten a feel for her yet? Like what she thinks, what she believes in?
I don't have a feel for her, but I will just say she's the acting Surgeon General. She's in the Commission Corps. So I think she's a public servant and not a political person. So I assume eventually they will be nominating a permanent Surgeon General, but they have a long backlog of positions to fill, so she could be doing that job for quite a while.
So I was going to make just a comment and say that you mentioned, Becky, that there are lots of healthcare reform and ACHA town halls going on, and even though you may not think that C. diff is directly related to those things, those are certainly town halls you could show up to. These are ancillary issues, and I think that talking about the Prevention and Public Health Fund is a great way to connect with people, and that is to me is like a completely nonpartisan issue. Unfortunately, it got trapped into into what became a partisan bill, but it's something that you can, I think, really work that angle in a way that is really about just public health in general.
And most of those town halls aren't even specific to health reform. They just sort of end up being all about health reform because that's what people are asking about. We have on Trust for America's America's Health's website, we have a lot of information about the Prevention and Public Health Fund. If anybody wanted to write a letter or get ready to ask a question, we would be happy to help you. But we did state-by-state analysis on how much funding each state would lose if the prevention fund goes away. Christian mentioned he used one of those numbers in the Ohio op-ed, which is great. We were thrilled to see it was put to use. So we have a lot of both our own analysis, examples of how the fund is being used in every state, examples of op-eds and letters to the editor and all those sorts of things. So we're happy to help anyone who wants to engage on that issue.
So speaking from the world of hospital epidemiology, infection control, and antibiotic stewardship, I would say that that regulations have been major drivers in enhancing infection prevention in hospitals, and now hopefully moving towards more in nursing homes also. And certainly those of us in the stewardship world for a long time knew we had to find a way to get regulations, because those are major drivers that make institutions act. So what do you think the strategy should be in trying to either preserve or advance the state of rational regulations in an administration that is very anti-regulation?
So again, you know, there is a theme of what's happening in the states, right? So I think, you know, this is a time definitely to look at each one of your state regulations and what is happening there, because frankly, it may be easier. I think then going back to the federal level, I think what's important there, you said one, preservation, but then two, educating on this, so that there's just not an automatic knee-jerk reaction. Like, this is different, you know? And I think there's still a case to be made on that, and we shouldn't right away think, oh no, we're already doom and gloom, you know? I think I would do it bi-directional. I would do your state work, county work, and then also be educating on the federal level.
And I think it's interesting, if you said you work at a hospital and you guys see the value of these regulations, usually if you're in an industry, the industry is arguing against regulations. So it just goes to show how important it is to have all these different messengers. And that's kind of an eye-catching, you know, like, we see the value in these. Like, you're a great person to make the case for that.
I think one thing I would do is kind of peel back the onion a little bit. If you look at some of the administration's reasoning for why they're opposed to regulation, a lot of it has to do with cost. And so if we can go back to some of our core messages about, look at how much antibiotic-resistant infections and how much C. diff is costing our healthcare system, we can save money by doing things to prevent these infections. We have reams of we have reams of data showing how antibiotic stewardship programs ultimately save money. So I think doing more education, but being very thoughtful about how we present those messages and talking in dollars and cents, because that is the kind of messaging that is impactful for this administration. Yes.
In terms of with C. diff, about 29,000 a year dead and about 500,000 contracting the disease. But as a practical matter, when the doctors sign off on the death certificates, I would assume that the proximate cause is usually C. diff, but they'll write down heart, kidneys, and what have you. And I think it might be a heck of a good idea if that were brought out, that if these figures are not 29,000, what 229,000, you'd have a different thing. And I think that the doctors are very negligent in that regard. They cancer, kidney, heart condition, but what killed them initially at this time, they're probably going to die anyway, but they killed them at this point, is C. diff. Do you have a comment on that? Because that, those figures, I mean, you got to scare these guys, and you got to have your figures to do it. These numbers range from 19,000 to 29,000. Okay, but what do you think on this? Do you have any numbers for us in that regard?
So I can take a stab at this, and from my sense, in talking with individuals at various hospitals as well as with CDC, is that our surveillance and our data collection is just not as robust as it needs to be. I think it's gotten better in recent years because the previous administration really made a point of making this a priority, and CDC got new funding to work with states and with hospitals to improve their reporting on antibiotic resistance, on C. diff, even on antibiotic use, which we know is kind of a key driver of these problems. But you're right, I think there is a lot more work to do on improving our data collection. I'll see if there's anyone else in the audience that may want to jump in with opinions on this. Christian, awesome.
So this is my current obsession, Joel, and there was a series done by Reuters last year that kind of exposed the patchwork system of our healthcare reporting and surveillance, and it's just a combination of what the hospitals do versus CDC versus the states, and there's just a lot of holes in the Swiss cheese, and death certificates in particular are problematic because doctors aren't really trained how to do them, and they're not reimbursable. I mean, I could go on and on, but the data, we need to have it be more robust. I think that's not, I don't think that's a particular failing of like the CDC, or I think it's just that it's not something that has been paid close enough attention to. And the way that cancer and all these other things became so important is that there were huge movements of people saying, my loved one counts, I'm gonna run for my cousin died of pancreatic cancer, and every year her daughter gets a group of people together to do the pancreatic cancer run walk. And so with infectious disease, it's a little tougher. So that's part of it. And I just want to say one thing about regulations, which is I think we have to be really conscious of the language we're using, and I think Amanda touched on this. And what I would say is, in a sort of anti-regulatory moment, I think we should stop talking about regulations and start talking about rights and start talking about protections. Your antibiotic stewardship program is there to protect me as your patient. It's not a regulation. And I think that's what Sarah was kind of getting at. Like, as an ID doc and somebody who works in hospital, she wants to protect her patients. And I think that if we get into that conversation instead of a regulatory conversation, it's less adversarial. You know, like, we want the doctors to write the right to use the drug that they want when, like as Bill was saying, you know, if there's a drug that you can't get on the formulary, maybe that's the best drug, and that could be bad for the patient too. So, so that's one of my things. I just think we have to really start getting people counted. We're going to be announcing a campaign a little later in the summer about how to make C. diff and other HIAs count, and you're all going to be sucked into it. So get ready.
Just adding to that, my most recent hospitalization with C. diff was as a result of the fact that my insurance company wouldn't pay for the vancomycin. So the only way the doctor could get me the medication was to be hospitalized. So I ended up being in the hospital for 2 weeks in a private room, all because my insurance company refused to give me the vancomycin to be treated at home. So I risked my life going into the hospital where I could have gotten sicker and sicker, all because my doctor fought with the insurance company, and he was on the phone with them for over an hour trying to convince them to not prescribe Flagyl but to prescribe the vancomycin. So that's the thing. I think Christian hit the nail on the head, where it's becoming, it's not a regulation, it's not anything, it's just about rights. Doctors shouldn't have to waste an hour on the phone with my insurance company because he feels that the only way for his patient to get better is to be on the correct medication, but there's just one stumbling block after another.
Yes.
Hi, Larry Brant's my name. I want to make a comment to the gentleman who spoke about physicians and deaths from C. diff. I grew up in medicine at a time when almost every patient that died in the hospital got an autopsy. And hospitals were evaluated based upon the percentage of autopsied cases. Today, I don't know the exact number, but it's probably somewhere between 0 and 5%. except for specific indications. And most of the patients that die in the hospital from C. diff are over the age of 65, and they have many comorbidities. And when they get to the point that the C. diff is really getting the better of them, when they die, they sort of just stop. And it's almost impossible from the clinical point of view to say this was due to a heart attack, this was due to a pulmonary embolus, this was due to kidney failure, this is due to the C. diff. And it's very, very difficult to tease that apart. So I think that it would be a very good thing from the educational point of view to increase the number of autopsies we do, because that's the ultimate teacher within the hospital setting. But I just read a statistic today that of all time that is spent in house staff training today, 2% is spent on education. 40% is spent in front of a computer. 30% is a face-to-face encounter with the patient. So unfortunately, American medicine is moving in a direction that is away from the face-to-face education that characterized medical education years ago. And although I'm not challenging your point, I just wanted to hopefully put it in a little bit of a perspective.
I would just want to add real quickly, that same issue, and just what you were talking about as well, the eating disorders folks have the exact same problem. We have flawed numbers on how many folks actually die of anorexia and other issues that folks used to come talk to me about. So if that is, just to say, if that is something, and we worked, when I was back there, we actually worked with CDC, we worked with other folks on trying to get them to work on this data, but you wouldn't be alone if you're trying to see on, actually getting on the death certificate what the person died from. There's other diseases and conditions that people are finding, because many times the anorexia, it's heart attack or other things, and you don't see anorexia. So just wanted to add that in.
That's a great point. Yes, you want to make a follow-up comment?
Is how much this costs. And it's not pretty. It's usually intensive care, and I think it was the University of Pittsburgh study that showed that if there were a vaccine, an effective vaccine, it would be worth to the government. I mean, these are crazy numbers. If it was 75% effective, like $1,600 a shot or a series of shots, and it was 50% effective, over $800. And that's the way to get to Brother Trump, in the sense that this is very, very costly. And I think that, I don't know if those numbers have been updated since the University of Pittsburgh. Perhaps you can tell me. And what's cooking in Europe? Do they have more up-to-date numbers?
I know that.
This may exceed the expertise.
I know the cost number that we often talk about is it's a little more general, but that $20 billion in direct healthcare costs. And $35 billion when you add in kind of societal costs, decreased productivity, things like that. But I think that's for antibiotic-resistant infections in general, and I'm not sure how much of C. diff is captured in that number. But we are always saying we need more data. That is kind of a running theme with IDSA. We need to do a better job of collecting the data and making those points. I think we need to kind of get to our last question, and so I want to pose this to the panel, and it's something that I think is going to be posed to each panel in a way that's sort of relevant to their topic. And so this is, what do you think is the most important thing that the federal government can do to impact C. diff?
Well, first, I think it's having conversations like this, frankly. I think it's critically important to have conversations like this, that it's not just a discussion just in the policy realm. I think of it just as a discussion in a technical policy realm. You only have a handful of people that are engaged in that process. And when you take it to a grassroots level at the state, at the federal level, where you have a multifold, what Amanda carefully laid out today in terms of advocacy and alliance development and the type of work your organization does, it's multifold. And I think if we look at this in a way, it's really a campaign, and you want to be able to reach as many people as you possibly can on so many different levels, where you even get state officials talking to federal officials. You have the outreach to the governor, outreach to the insurance commissioners, the NAIC that represents the insurance commissioners, the person who had really harrowing experience in the healthcare system. I think you have to look at this in like some of the charts we saw about those were complicated, but I think you have to look at it in the same realm. And when you want to advance something from a public policy perspective, if you want to increase funding, you want better attention to a specific disease, you have to go at this from 50 different directions. I think that's really critically important. And again, your voices matter tons, and believe me, if you engage, you're going to have a return on your investment of time. I guarantee you will.
Yeah, I agree. And I think that this, like many public health issues, unfortunately does not have a one silver bullet answer. If it did, all of our jobs would be a lot easier. The data collection, making sure we have strong regulations or protections, making sure we have funding for a robust public health system that has the capacity to gather that data and do the surveillance and have the hospitals talking to each other. So I think, it's a mix of making sure that we don't haphazardly slash funding for public health all around across the board, making sure people are educated. I'm actually going to pick up on something Janelle mentioned about educating around the incentives for antibiotics versus the broader views of the pharmaceutical companies. And even a lot of progressive organizations that would be very supportive of public health funding don't necessarily get that difference in incentives versus the drug pricing. So even educating other advocates is a really important part of this. So I think it's just kind of engaging and doing more work like this. You guys are doing great work.
I think, sitting from the position that I'm in at Merck, the biggest thing that the federal government could do right now is really deal with this incentive piece of this. I mean, you all see where the pipeline is on antibiotics, and unless they start making the market work and that this work, we are going to lose more and more people, or manufacturers. And so all of it needs to be done. Don't get me wrong, but we just have not done the federal government has done nothing in the incentive side of things, and that really needs to happen quick.
So I guess I get to have the last word for the panel, and just in kind of thinking about all of the areas we've been talking about, whether it's research, whether it's better patient care, stewardship, infection control, we need people. We need a robust workforce of public health practitioners and infectious disease doctors and nurses and scientists and people going into these fields. And many of these fields are not very valued by the federal government. People don't make a lot of money by being scientists and doing research and figuring out the answers to these tough questions, or doing the public health work and collecting the data and doing the epidemiology. Even within patient care, infectious disease, you don't make anywhere near the kind of money you make doing surgeries and all these other areas. So investing in the people that we need to keep us safe and to drive innovation, I think, is going to be essential.